You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. The following podcast is titled Lipid Legends, featuring Dr. James Underberg. Familial Hypercholesterolemia, Risk Assessment and Treatment. And there is no commercial support for this activity. To earn CME credit, log into mededtalks.com and search Lipid Legends, or click the link in the notes section of this podcast to go directly to the activity, take the test, and complete the evaluation. Before beginning this activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives. Now, here's your host, Dr. Ron Codario.
Hello, I'm Dr. Ron Codario, Medical Director at Vindico Medical Education. I'm joined by my friend and fellow lipid colleague, Dr. James Underberg, Clinical Assistant Professor of Medicine at the NYU Grossman School of Medicine, NYU Langone Center for Prevention of Cardiovascular Disease, Director of Bellevue Hospital Lipid Clinic, and the past president of the National Lipid Association. So welcome, Jamie. Great to see you and work with you again.
Ron, great to be with you and excited about our conversation today.
So in this episode, we're going to summarize the latest evidence regarding the diagnosis and treatment of familial hypercholesterolemia. So Jamie, before we begin, how did you develop an interest in lipidology?
Like everything else in the field of medicine, it's an evolving process. I started out my training after a background in basic sciences. I was going to be a biochemist and got a master's degree in biophysics and biochemistry. And as part of that training, I had to take some basic science courses. And one of them was a course called The Molecular Basis of Inherited Disease. And we had two lectures on the discovery of the LDL receptor by Doctors Brown and Goldstein. And I never forgot that lecture and where I was sitting when I heard it. We all have these seminal moments, and for me, that was one of them. And years later, I finished my training in internal medicine after I decided to pursue the field of medicine right when statins were first being made available in clinical practice. And it circled back to my interest in biochemistry and prevention. I always felt if you were doing a good job as an internist, you were preventing cancer and heart disease. And heart disease prevention was starting to seem far more actionable to me at the time. And I think because of my background in biochemistry, the lipid pathways just made sense to me. I can see them in my head, and it was easy for me to understand how things work. And it just happened that several years later after that, I happened to attend a lecture from our friend and colleague, Tom Dayspring. And he gave a talk on the difference between lipids and lipoproteins, another seminal moment early in my career. And I owe a lot of my interest in the field, as many others do, to Tom. And I was at NYU and Bellevue Hospital. I was lucky. One of my residents when I was an intern was someone named Terry Jacobson. Terry ultimately went on to run the lipid clinic at Penn and now at Grady Hospital in Atlanta. And Terry had since left, but I was talking to him about my interest in lipids. And he said to me, "Why don't you just start a lipid clinic at Bellevue?" And I said to him, "Can I do that?" And he said, "It's Bellevue. You can do anything you want." And so I started a lipid clinic at Bellevue. And before long, like anything else, when people see you're interested in something, they start sending you patients. And this was even before the National Lipid Association existed. But, I pretty soon after that found out there was a group in the Southeast that was interested in lipids, the Southeast Lipid Association, and I joined. And that ultimately morphed into the National Lipid Association. And I was lucky enough to be involved in the early formation of the Northeast chapter. And my involvement with the NLA has continued ever since then. So it's been a great story for me. And it just, when I speak to my trainees, I always tell them, follow your heart and your interests. It will lead you where you want to go. And that's one of the unique things about medicine is you kind of develop it as you go. I know your career also has been one of many twists and turns, and I think you just have to follow your interests.
So what are your hobbies or special interests beyond medicine?
I play the drums. I play pickleball with my wife. I spend time with my family. I like to read. I love historical fiction. And I like to travel. So those are my interests.
So let's dive into the topic. How are the diagnoses of heterozygous FH and homozygous FH established, their respective onset as well as their response to therapy and prevalence?
So familial hypercholesterolemia, as you know, is an inherited condition of cholesterol metabolism. It's caused by a defect in the ability of the hepatocyte to remove cholesterol from the plasma. This is usually a defect in the LDL receptor caused by a mutation in the gene controls the LDL receptor for the formation of it in chromosome 19, or many of the other proteins that impact the function of the LDL receptor, such as the ApoB gene, PCSK9 gene, or the LDL adapter protein. It's an autosomal codominant condition, which means you only need to have one affected allele to express the phenotype. And it's associated with extremely high cholesterol levels from birth, and associated along with that, an increased risk of atherosclerotic cardiovascular disease. Typically in the heterozygous, more common presentation, about a decade to 15 years earlier than would be normal. So in the 40s and 50s for men and 50s and 60s for women, the more severe homozygous presentation, you can see the development of atherosclerotic disease as early as the first decade of life. The diagnosis can be made clinically or genetically. Clinically, it's based on the LDL cholesterol level. Typically, heterozygous FH, the LDL is above 190 milligrams per deciliter. If one wanted to know where that comes from, if we think of the average LDL cholesterol or mean LDL in the population as being somewhere between 100 and 130, if you only had half of your LDL receptors, you would expect to see twice the LDL cholesterol, or an LDL somewhere between 190 and 230. And so 190 is generally considered the 95th percentile for cholesterol, which is another reason people often use that. But in addition to the LDL cholesterol, we look for a family history of high cholesterol, a family history of premature atherosclerosis, and then there are certain physical findings that people can develop, manifestations of cholesterol deposition in the skin. It can form xanthoma that can be on the surface of the skin, plaque-like lesions called planar xanthoma, kind of a yellowish orange color to them. Cholesterol deposits in the extensor tendons, primarily in the hands, the elbows, knees, and classically in the Achilles tendon. And in addition, in cases of more severe cholesterol elevation, you can see the development of something called xanthelasma. But xanthelasma is not pathognomonic for the condition because you can have xanthelasma with normal cholesterol. And xanthelasma are actually reactive giant cells. They're not cholesterol deposits. So the presence of xanthoma does not mean you will have high cholesterol. Finally, corneal arcus, typically inferior and superior as opposed to circumferential, and that has to do with the blood supply to the eye. And so you can make a clinical diagnosis based on scoring systems, such as the Dutch Lipid Clinic Network scoring system, or the Simon Broom, which is the UK version. You can make it simply based on LDL cholesterol and family history, or you can do genetic testing. And to diagnose heterozygous FH, it's one mutation in a gene known to be associated with FH, LDL receptor, ApoB, PCSK9, or the adapter protein. Homozygous FH, you need both. For homozygous FH, to make the diagnosis clinically, the LDL is typically above 400, or we sometimes say 300 on maximal oral therapy, which would be statins and or ezetimibe. No reason to stop lipid-lowering medicines when someone's LDL is above 300 to find out what it might be off medications. I think that would be inappropriate. Genetic testing, as I mentioned, obviously, in family history.
So how do heterozygous FH and homozygous FH differ in terms of their onset of coronary artery disease, their response to therapy, and their prevalence?
We'll start with prevalence first. Your last question, and I'll get to it first. Heterozygous FH, typically globally, we think 1 in 250. When we were training, and I'll group us together, we were taught 1 in 500, but it's probably closer to 1 in 250. And I will tell you, in my neck of the woods, in the tri-state area of New York, New Jersey, and Connecticut, probably closer to 1 in 150. And that's because of the increased prevalence of what we call founder populations, or groups that are at greater likelihood of having FH, such as patients from Lebanon, Ashkenazi Jews, French Canadians, or South African Afrikaners. Homozygous FH, we used to think was 1 in a million when I was training, but that is probably closer to 1 in 250 to 1 in 300,000. So if you think 1 in 150 or 1 in 200, and you speak to a typical practitioner, ask them how many patients they see a day, some people see between 15 and 25 patients a day, depending on the practice. You could imagine you should be seeing 1 or 2 of these patients a week in clinical practice. We can get to how often that gets recognized and diagnosed, but the prevalence obviously varies from one place to the other. The diagnosis, again, is based on LDL cholesterol levels. Patients with homozygous FH can develop signs and symptoms of atherosclerosis as early as the end of the first decade of life, sometimes even sooner, depending on how severe the condition is. Heterozygous FH, men in their 40s to 50s, women in their 50s to 60s, so about a decade sooner. The increased risk of heart disease in patients with heterozygous FH over the course of the lifetime is about 1 in 20 times greater. But if you do it based on age, just as an example, for a woman in her 20s, her risk was actually be 125 times greater compared to an age-matched control. Partially that's because the baseline risk is so low, the metrics seem so high, but I use that as a tool to remind people that the disease needs to be treated early in life, because cholesterol accumulates from day one. So it's not just how high is your cholesterol, but what's the cholesterol burden, kind of like pack years in cigarette smoking. How many cholesterol years have you been exposed to?
The phenotype of FH can reflect LDL receptor, ApoB, or PCSK9 mutations. How does that apply at the clinical level, at the cellular level, I should say, to with regard to the causes of FH?
Depending on the underlying mutation, that can reflect severity, meaning is it a complete loss of function of the receptor, or is it a partial loss of function of the receptor? And so you can have 2 different mutations in the same gene, meaning the LDL receptor or the ApoB gene, but they can have different degrees of severity depending on the type of the mutation. What's unique about familial hypercholesterolemia is that for a monogenic condition, meaning one that is impacted by mutations in just a small number of genes. Typically, in these disorders, we only see a couple of different mutations as causing the condition. But in familial hypercholesterolemia, it's somewhere in the 1,500 to 2,000 range for the number of known mutations, and continues to grow. And part of the reason for that is the complexity of the LDL receptor structure. It's a rather complex architecture and scaffolding held together by disulfide bonds. And any small change in that structure can cause a shift in the way the protein is constructed that leads to an abnormality in the way the LDL particle binds to the LDL receptor that can impact the phenotype or the degree of LDL cholesterol elevation. So it really depends on the exact changes that take place in the structure of the protein itself.
Yeah, and we know that these genetic abnormalities have been associated with, as you mentioned, defective LDL receptors from chromosome 19, defective ApoB 100 from chromosome 2, PCSK9 gain of function mutation from chromosome 1 and IDOL, and autosomal recessive FH in chromosome 1, and the STAP1 chromosome 4 abnormalities have all been described.
I would tell you the ApoE gene also may play a role in FH. The idle receptor is fascinating. PCSK9 is a way of moderating the breakdown of the LDL receptor, and we know that people can have complete loss of function of the LDL receptor, but their cholesterol level does not go to 0. And I love asking my trainees why. And the reason why is, like everything else, there's a backup system. And the backup system for LDL is the idle receptor, intracellular degrader of the LDL receptor. So as PCSK9 function drops, idle actually upregulates. And so there's always a way to make sure we have a little bit of cholesterol in the body.
Please review the cardiovascular risk of patients with FH, especially at an early age when compared with the risk in the general population.
So as I mentioned, the lifetime risk is probably twofold increased. Um, it's interesting when you compare this to other, what most people would call common inherited conditions, it clearly outpaces everything else. And it's a common condition when compared to things that we often think of as some of the other conditions one would see. But the risk, as I said, it's about 20-fold over the course of the lifetime. But as you get younger, that relative risk increases.
So summarize for us the various guidelines for hypercholesterolemia screening, particularly the American Academy of Pediatrics, the European Atherosclerosis Guidelines, and the ACC/AHA adult guidelines with regard to screening for hypercholesterolemia.
Both the American Academy of Physicians and actually the NIH suggest that all kids should be screened between ages 9 and 11. The reason we choose ages 9 and 11 is that's before puberty typically, when cholesterol starts to go haywire for a couple of years. And so standard screening for everyone should be 9 to 11. Unfortunately, this isn't happening the way it should for a variety of different reasons. Um, the European Atherosclerosis Society also suggests ages 9 to 11. The American College of Cardiology, the American Heart Association recommend universal screening for all adults at age 21. And that's actually in the adult guidelines also. I will tell you that we also recommend targeted screening as early as age 2 in kids whose parents have a history of FH or a history of high cholesterol or premature atherosclerosis. And the reason for that is not necessarily that you would treat a child as early as age 2, depending on the severity of the condition, you might, but you certainly would want to make sure that you were aware of the condition so you could adjust for appropriate lifestyle and dietary modifications that you would want to incorporate as early as possible.
So what are the gaps that exist based on these guidelines and the Cascade Registry data?
So the Cascade Registry, just for those who aren't aware of it, is our U.S. registry for patients with familial hypercholesterolemia. It's now run by the Family Heart Foundation, and we were lucky enough to be involved in it when it got started and be involved in some of the publications. So what we did early on is we actually recruited data from lipid specialty clinics around the country, folks like myself and others who manage patients with familial hypercholesterolemia, and looked at a variety of different data sets. And one of them was at what age were people being diagnosed with FH, and at what age were they started on statin therapy? And I will tell you, these numbers to me were quite disheartening when I initially saw them, because remember, this is not all comers. These were lipid specialists and lipid clinics. The typical age of statin initiation in people with a lifetime history of high cholesterol was almost age 40, age 39. And the time of diagnosis was age 47. Now, I'm hoping since the years that this was published, we see these numbers shift to the left to a lower age. And I think there's been a tremendous amount of awareness around this condition through a variety of different reasons and sources. But diagnosis itself is also very low. When you actually look at the condition worldwide, these numbers are extremely low. One of my fellows published a paper several years ago. She actually won the NLA Young Investigator Award. And we looked at a data set that we had here in New York, and we found that the diagnosis rate was close to 1%. 1% of folks who had obvious signs of FH were being told that they had some form of inherited cholesterol condition. We didn't even require that they be told they have FH. Global data suggests that rate is closer to 10% in the US now. I'm not sure I completely believe it, but hopefully it's getting better.
Does that data underscore the importance and the value and effectiveness of cascade screening in patients with FH?
It does. And cascade screening means that once you identify the index patient, you then want to screen all first-degree relatives. And I always remind people that first-degree relatives is not just the kids. It's north, south, east, and west. So it's parents, siblings, and kids, and any other relatives that might be affected, such as first cousins, et cetera, that might be related to the index patient. And there's been really good data showing that cascade screening increases adherence, it increases identification of patients, and it also helps patients get treated appropriately. So there's a real role for cascade screening. We have a standard letter that we give our patients in clinic when they've been diagnosed, telling them to take it to their pediatrician and mail it to their relatives, because unfortunately in this country, we can't just reach out and call family members and get them screened. Screening can either be a known genetic test if you have a genetic mutation that's been identified, or you can simply do a lipid panel on folks.
What are the current available therapies for LDL-C lowering in patients with FH, especially the mechanism of action and efficacy of the ANGPTL3 inhibitor evinacumab in treating homozygous and heterozygous FH?
I'm lucky. I've lived through the evolution of these products. When I was a intern and resident, we were treating folks with bile acid sequestrants and niacin. Niacin is no longer recommended in the management of lipid disorders, and bile acid sequestrants are really left for patients with FH after you've tried everything else. But we now have statins that lower LDL cholesterol. They block the production of cholesterol in the hepatocyte by inhibiting the rate-limiting step in cholesterol synthesis, HMG coenzyme A reductase. That leads to an upregulation of the LDL receptor, increasing clearance of cholesterol from the plasma. Ezetimibe is an inhibitor of cholesterol transport, active transport in the proximal jejunum. And so cholesterol is not absorbed at the same rate. And so there is decreased cholesterol return back to the hepatocyte, again, leading to an upregulation of the LDL receptor. We have monoclonal antibody PCSK9 inhibitors, evolocumab and alirocumab, that work via inhibition of the protein PCSK9, which essentially delays degradation of the LDL receptor and makes it more available to clear more cholesterol. Another form of inhibiting PCSK9 is its production, and that's done with an siRNA called inclisiran. Ultimately, also works via enhanced expression of the LDL receptor because of delayed degradation. Bempedoic acid is an additional inhibitor of cholesterol synthesis, a little higher up in the cholesterol pathway, and it works by blocking acyl-CoA, and you have decreased cholesterol production. It's activated in the liver by an enzyme that's specific to the liver, so it doesn't exert its action outside of the liver. You don't see the musculoskeletal side effects that you can see with statins. It's not quite as robust a lipid-lowering agent because of the fact that it's not the rate-limiting step that it inhibits. And so beyond that, you asked about inhibition of ANGPTL3. And ANGPTL3 is a protein that's involved in suppressing another very important protein in the liver and expressed elsewhere too, called lipoprotein lipase and also endothelial lipase. And it was first identified that patients who had deficiency in ANGPTL3 had very low levels of LDL cholesterol, HDL cholesterol, and triglycerides. And genomic analyses, such as Mendelian randomization, showed it was associated with a reduction in ASCVD event rates over the course of the lifetime, too. And so it turns out that if you inhibit ANGPTL3, you relieve the inhibition on lipoprotein lipase and endothelial lipase. And so by upregulating them, you convert more VLDL into LDL, actually first into remnant or IDL, and then ultimately theoretically LDL. And patients with homozygous familial hypercholesterolemia have no function of their LDL receptors in the more severe cases. the typical lipid-lowering agents that I discussed earlier that all work through the LDL receptor don't have much role in managing patients with homozygous familial hypercholesterolemia because there's no LDL receptor to upregulate. Interestingly enough, though, in these patients, even evenacumab, an inhibitor of lipoprotein lipase by inhibiting ANGPTL3, upregulating lipoprotein lipase by inhibiting ANGPTL3, does lower LDL cholesterol significantly, almost 50% in clinical trials. And it turns out the reason this happens is that by blocking ANGPTL3 and you upregulate lipoprotein lipase, you create more remnant lipoproteins. But by also inhibiting endothelial lipase, you change the conformation of these remnant lipoprotein particles, making them more likely to be taken up by naturally active remnant receptors on the surface of the liver. And so you essentially bypass the dysfunctional LDL receptors and direct remnant lipoproteins back to remnant receptors on the surface of the hepatocyte, not allowing them to actually be transformed into LDL. It's a fascinating mechanism. We're learning more about it every day, but it's a great way to treat patients who have no LDL receptor activity because the typical medications that I discussed won't work in those patients.
Now discuss for us the 2022 ACC expert consensus decision pathway on the role of non-statin therapies for LDL cholesterol lowering in the management of arteriosclerotic vascular disease in those people with baseline LDL-C equal to or greater than 190 milligrams per deciliter, in those that have known coronary artery disease and those that do not have known coronary disease.
So we're basically talking about patients with FH with and without ASCVD. And the 2022 expert decision pathway that you're referring to, which can be downloaded, you don't have to be a member of ACC or subscribe to the journal to download this document. It's a wonderful document, and I think it's worth reading for anyone involved in managing patients in the lipid space, kind of bridging the gap. So we have the next set of guidelines, hopefully in the next year or so. Focuses on what to do after statins in these patients. And the bottom line is that for anyone with FH, you want to achieve an LDL cholesterol reduction greater than 50%. In patients who have underlying ASCVD, in addition to that 50%, you want to get their LDL cholesterol down below 55 milligrams per deciliter. If they don't have underlying ASCVD, then the threshold for intervention would be an LDL of 100 milligrams per deciliter. And after a statin and/or ezetimibe, the recommendation is a PCSK9 inhibitor. A monoclonal antibody would be the first recommendation by the expert panel, followed either by bempedoic acid or inclisiran. And I just talked a bit about both of those. In patients with homozygous familial hypercholesterolemia, one can also consider therapeutics specific to homozygous FH, which represent the evenacumab we just talked about, or another drug specifically approved for patients with homozygous FH called lomidopide. Finally, there's also a role in these patients to use LDL apheresis if one can't control cholesterol appropriately. So we have a tremendous number of tools now available to us to help manage patients with FH. The key is recognizing them and getting them to someone who will use them.
The Odyssey FH1 and FH2 and the Rutherford 2 studies have commented on the efficacy of alirocumab and evolocumab, respectively, in patients with FH. What did these results tell us in terms of their efficacy?
So they tell us that the LDL lowering that you would expect to see in patients with familial hypercholesterolemia is relatively similar to that what you see in the overall population of patients treated, which is around a 50% reduction in LDL cholesterol. That's what one would expect. Remember, these patients, the ones with heterozygous FH, have functioning LDL receptor. They only have half the amount, so they happen to respond particularly well to drugs that upregulate the LDL receptor. These are the patients with heterozygous FH. It's actually the same story for statins and even bempedoic acid. The patients with FH respond even better to therapeutics that focus on the LDL receptor. I always say it's kind of like treating patients with a sore throat. If you gave everyone with a sore throat amoxicillin, you would think it was a lousy drug. But if you only gave it to people with streptococcal pharyngitis, you'd say this is an amazing drug. And it's the same thing with drugs that focus on the LDL receptor. They work really well in FH. They just need to be used.
What have the data shown us about the siRNA PCSK9 inhibitor inclisiran in patients with heterozygous FH?
Similar data, actually. In these patients, you can see north of 50% reduction in LDL cholesterol in patients with heterozygous FH, with safety data that I would say, broadly speaking, is similar to that with other therapeutics in the space that work on PCSK9. These drugs can also be used on top of statin therapy and or ezetimibe or other lipid-lowering agents. The potential kind of difference maker here with the siRNAs is they don't have to be given as frequently. So instead of injecting every 2 weeks, they can be injected every 6 months, which from an adherence perspective might potentially be beneficial in some patient groups. So there's some interesting, potential targets of groups of patients that might benefit from this over others.
What has the data told us about the efficacy of bempedoic acid in treating patients with heterozygous FH, particularly changes in LDL cholesterol in those people who've had a background of statin and ezetimibe therapy?
So it's interesting. Again, the patients with FH seem to respond a little better than the overall cohort or patients without heterozygous FH. And I told you earlier, bempedoic acid, unlike statins, which inhibit HMG coenzyme A reductase, which is the rate-limiting step for cholesterol synthesis, bempedoic acid inhibits a different enzyme that is not the rate-limiting step. So it's less robust a change in LDL receptor. There is an added effect between statins and bempedoic acid. But when used on top of statins, in patients with FH, you see somewhere around 23-24% reduction in LDL cholesterol. When used in overall cohorts, it's somewhere between about 17 to 18%. So again, greater response in patients with FH.
We mentioned earlier that the disease, the FH, is underdiagnosed in the United States and probably worldwide. And as with many other diseases, to reduce cardiovascular disease and subsequent events, early detection is critical. So what are your final take-home messages to physicians with regarding the improvement in diagnosing FH and improving our areas of suspicion to screen these individuals and get them into therapy?
So people often ask me this question: why does it matter if it's high cholesterol? I'm just going to treat the cholesterol. And my answer is that couldn't be more wrong, because inherent in making the diagnosis is the immediate understanding at how high risk these patients are. It also makes you realize that they've had cholesterol from the day they were born. And so the exposure over the course of their lifetime to high cholesterol, the cholesterol burden, is what determines and drives their increased cardiovascular risk, which leads to the idea of the urgency of treatment, that these patients need to be treated as soon as possible. It's even more important in women because there may be a period of time during childbearing where women may not be on some of these medications. And so the earlier you capture treatment, the better it is for a lifetime reduction in ASCVD risk. And data suggests that if you treat kids sooner, they do better than their parents who are treated later in life. And so early identification, diagnosis, getting folks to specialists or folks interested in who understand how to take care of these patients and will utilize the appropriate medications is so important to the understanding and management of this condition. I can't emphasize that enough.
Well, thank you, Dr. Underberg, for this excellent discussion. And thank all of you for listening. Please remember to take the post-test and evaluation to receive CE credit and to tune in for any additional episodes in this podcast series. Thank you.
Thank you for listening to MedEd Talks Cardiology. Just a friendly reminder, CME credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends.